I think one of the emerging problems now is the transparency gaps. It's become very confused over the last few days about what the actual numbers are and what they mean. We've seen a couple of days now where the apparent death toll has gone down. At the same time, the government's been talking about what's included, what isn't included, whether it includes community deaths or not. They've talked about the delays that there are in registering deaths and how it varies from hospital to hospital, which I find difficult to believe. I mean, you know, how you can't have a person in the hospital whose job it is to do the tally and report in every day. It doesn't have to go through a bureaucratic process to actually do a count each day. And this confusion about whether it's moving over to weekly reports from daily reports. And, you know, this is causing a lot of muddying of the waters out there in the community. People are worrying that the figures might be about to be fudged, and that's disturbing. I mean, that's part of this whole trust issue, which isn't helped by leadership not leading from the front, by seeing that VIPs get access to tests and other people don't, particularly frontline workers. So, you know, there's this transparency and trust thing, gaps in the information that are important, like people have been asking, frontline people, directors of public health have been asking to have access to the 111 calls, the numbers of people who are phoning in for advice, because in the absence of testing data and the absence of other kinds of robust, reliable data, having some knowledge of how many people are phoning in with symptoms from different parts of the country can be taken as a proxy for what's going on, gives an idea of where the problems are. And another similar issue is that the failure to publish the number of intensive care beds and the numbers that are occupied around the country. My understanding is that Channel 4 have been trying to get this out of the government, but without success. So, you know, these are issues that really lie behind the need to be open and transparent, and which has been a problem all the way through. It's the same with the test results themselves. And as the testing ramps up, hopefully, I mean, we keep getting promises of 25,000 tests a day, but apparently it's gone down in the most recent days again. And making promises that you can't deliver on undermines the trust of the public. And if you want the public to stay with you, then you've really got to, you know, deliver on promises, be true to your word, and all the rest of it. We've seen what can happen in parts of Italy now, where there's beginnings of social unrest. We don't want to see that here. It was something I anticipated at the very outset weeks ago, was that the need to take the public with you all the way through this difficult time with very difficult decisions, including constraints on freedom and freedom of movement, that, you know, if you don't want to finish up with trouble on the streets, you've got to really lead from the front and in the right way. Well, we really don't know what's going on about the testing. You read different reports. One of the things that is obvious to anybody who looks at it with the cold light of day is that in order to do systematic testing, you need enough PCR machines, you need reagents and enzymes and swabs and people to do the testing. Whichever is the least of those is the most tests you can do in a day. You know, if you haven't got enough swabs, that's as many tests as you can do. If you haven't got enough reagents, that's as many as you can do. And it looks as though there's a shortage of reagents now, so that even if they get enough machines, there may be a limit on the number of tests they can do. Now, this is something they should have anticipated from the outset. There doesn't seem to have been like a quartermaster in charge of the stores, the national stores, keeping a track of the national inventory and ordering stuff well in advance of when it was needed. It's just, again, this failure to anticipate and to order. And we're at the back of the queue now because we didn't order when other countries were ordering. So, you know, we see the Deputy Chief Medical Officer and we see the Medical Director of Public Health England saying over and over again, this is going to happen. But, you know, the timescales, we really don't know. So that puts us in the dark. And it relates to another issue, which actually one of the viewers has asked the question about why the government's decided to downgrade the status of the epidemic at the end of last week from HCID to HA3G, to the high consequence infectious disease is the HCID, downgrading it to hazardous of the third group, HA3G. Apparently, you know, I've been trying to get to the bottom of this, and it seems that the four nations, that's England, Scotland, Northern Ireland and Wales, and the Advisory Committee on Dangerous Pathogens decided to do this. And the justification that they've offered for this is that the mortality rate is low overall. You know, it looks as though from some of the countries with the overall data put together that the mortality rate may be about 0.6 or 0.7 per thousand. So they're saying that because the mortality rate isn't very high, but actually that may still be higher than the influenza, and that there's a potential for dealing with it by testing. So, but that's a chicken and egg argument. I mean, if we were doing what we should have been doing, then maybe there is a case for changing the status of it from being a high consequence infectious disease to being in this lower group. The characteristics of a high consequence infectious disease are several. They are that it's acute, it's got a high case fatality rate, there's no effective treatment and no effective prevention, it's difficult to recognize quickly, it spreads in a healthcare environment, and it requires an enhanced systematic and systemic response. Now, actually, it looks as though coronavirus fulfills pretty well all of those things. And the downgrading of it to this other category has the consequence of meaning that you don't have to treat it in specialist infectious disease units. So, you know, maybe what's going on here is that they're redefining it so that they can treat it in other places than infectious disease units because we haven't got enough beds in infectious disease units. And similarly, that by redefining it, it now fits the new guidance that Public Health England has issued about personal protective equipment, which is a lower spec for personal protection equipment. So this looks like a circular argument that you're redefining it, rewriting the story to justify regarding it as a lower severity virus and infection. So, you know, I think this requires really close interrogation. And I think a lot of people were very suspicious of this when they saw this happening. On the question of ventilators, you know, this is quite confused now. It's quite a mucky story. There seems to be a lot of politics involved. It does look as though there was a real muddle with politics involved earlier on about whether or not to get involved with the European Union, you know, purchasing and so on. And I don't suppose we're going to know the truth of that till this is long over and there's a legal inquiry into the way in which the whole thing was conducted. But in as much as this may have been caught up with the Brexit mentality, the thing about, we're standing on our own 2 feet, we don't need Europe. If there's any truth in that, then, that is a disgrace. If there's any truth in that, when what mattered was the government really doing what was needed to protect the people of this country. I think what's happened over the last 4 or 5 days is that there's something like panic going on in the central group. You've had these senior figures going off sick, and a real issue about keeping the show on the road at a national level, with the Prime Minister being sick, the Secretary of State, Chief Medical Officer, and so on, all these figures being unwell. And the criticism which has been leveled about the continuing response, I mean, I've said before, we really need to set aside the blame game and the recrimination for where we are now, but what's important is to learn those lessons for going forward about the need to get the testing in place, to protect the frontline workers, to be committed to openness and transparency of the data, which we've been talking about. But in this sort of meltdown, sort of confidence meltdown, I think, of the centre, then there had been a bit of hitting out in all directions, and blaming the Chinese again is really unhelpful. I mean, the Chinese may have been slow to report this at the very beginning. Maybe they didn't report from December into January, but more recently they've been extremely helpful. They've published all of the workbooks and the lessons learned on the internet. People can download them, they can look at them, the treatment protocols and everything else. Incidentally, the treatment protocols, it looks as though we're busy rediscovering the wheel here, when there are actually protocols that the Chinese have used that could be downloaded and made use of. So we've got that hitting out in all directions. The other thing that's gone on just in the last 24 hours is that they've been busy bringing in retired senior civil servants who've been experienced in dealing with major disasters and major incidents in the past. So this seems to be an admission that they haven't got the right people at the heart of this. And hopefully they will be able to come in and help out now and draw on that experience. And, there is a lot of experience in the country, but it does seem as though there's been this tight cabal that hasn't been willing to really embrace the different perspectives, the different scientific disciplines, the different experiences at home and abroad that might have put us in a better place. And hopefully we will now get to grips with that. When we go beyond the overview of the population at large and those people who are at risk in terms of their age or other vulnerability, having had a history of heart disease, diabetes, chest disease, or compromised immunity for one reason or another, including things like cancer. When we go beyond that, and we go beyond thinking about the frontline workers, the health workers, who we really are morally duty-bound to protect, then we have to look at other groups. And the other groups include people in closed institutions, the likes of prisoners. There's increasing attention on the situation of prisoners now, particularly since there are infected prisoners and prison officers in more than 10 prisons around the country, often in the old Victorian prisons, having 2 or 3 men in a cell that was intended for one person. The overcrowding and the poor environmental conditions, this is really disturbing. So far, the Prime Minister has refused to release early prisoners who don't pose a threat to society and who are coming towards the end of their sentences. Now, that is a crazy situation. The same is for people living rough on the streets. It looks as though we're making progress on that. There seem to have been quite a large number of people now offered accommodation in hotels and the like, but we still need to bash on with that. There are other groups like sex workers and drug injectors for whom the services have been badly affected by the austerity cuts in the last 7 years since 2013 with the changes in public health and the budget cuts. And we're really, the lesson from the Victorians, the lesson of enlightened self-interest, is that if you don't pay attention to those groups, then it'll come back and kick the comfortable classes in the backside, because that can be a vehicle for spread of the infection. And we have to really, as my mentor, the late Professor Lowell Levin, used to say, sometimes you have to forget your principles and do the right thing. So even if you may have particular strong views against prisoners, against sex workers, against drug users, there's a time when you have to forget your principles and do the right thing and make sure they are looked after really well, because they not only are jeopardized themselves, but they may jeopardize the health of the population as well. There are other groups that really are in jeopardy at the moment. Thinking about women about to give birth, where it looks as though home birth is off the agenda in many places now. And midwife-led units have been closed because it seemed to be convenient to consolidate the maternity service into the hospital. But if the hospital environment has become unsafe because it's become contaminated, this is really worrying. There's some indication of the government responding to concerns about the availability of contraception and abortion, and the morning after pill and the abortion pill itself now being made more readily available. But you know, you have women who are stuck in really difficult circumstances. They may be stuck in a house or a flat with an abusive partner, unable to get their contraception, and where this is a particular issue for them. Similarly, with mental health services, it looks as though young people in particular are particularly vulnerable. Those who've got serious mental illness, those with OCD, with obsessive compulsive disorder, can be particularly badly affected with their anxiety states in these kind of circumstances. And, you know, many psychiatrists appear to have been diverted now to be doing medical work in looking after corona patients. So the Child and Adolescent Mental Health Service, which was struggling at the best of times, is not really in a position to respond to these. These are all things that have to be kept on the radar. They have to be responded to. And what we probably need to do in this circumstance is to find ways of supporting their carers, their loved ones, in handling those situations better, because professional help is not just round the corner. It won't be there for some time. Again, it's one of these things where we have to mobilize the community assets for mental health, support people in mutual care for these things. So these are some of the areas, together with child health itself quite generally. We've got to look out for the kids, because this is obviously a troubling time for them. One of the wonderful things that we've seen over the last month or so has been communities all around the country organising themselves, getting together, sorting out who's going to do the shopping for people, who's going to keep an eye on people, who's get the medicines and all the rest of it. Fantastic, all over the country. And then since last week, we had the NHS request for volunteers to support the NHS, 750,000 volunteers, fantastic. So what we've got there is two separate initiatives. We've got the bottom-up, community self-organising, and we've got the top-down, the NHS asking for volunteers. What we really need is to get these to meet in the middle somewhere, because it needs to be joined up. This can't be about professionals being on top and telling volunteers and communities what to do. This has got to be a genuine partnership, you know, with professionals on tap and in partnership, not on top. And what needs to happen really is for the NHS and the social services and all those statutory bodies to be saying to the community, how best can we support you? Because you are carrying the brunt of this. You're going to be carrying more of this over the next week, 2, 3, 4, through April into May, as the numbers continue to increase. And we need to see how we can support you rather than just asking how you can support us. One of the saddest things, most moving things of the last few days has been the death of these 3 doctors working in the NHS to save life. 3 doctors who noticeably have Arabic names. And when you consider the xenophobia that this country's experienced in recent years, and how unpleasant it's become for many people who have got backgrounds from other parts of the world to be here working, then it really should make us sit up, feel some shame, and really understand that we have in this country some fabulous people from all over the world and who play such a major part in this treasured institution of ours, the National Health Service. I think despite the problems that we've had, you know, the slowness of response and all of those things, we seem to be in a better position than the United States, where the levels of inequality are greater even than our own have become in recent years, and where the homeless phenomenon is massive, and where they don't seem to have been able yet to address in a humane way how to accommodate people on the street, rather than just chalking out zones for each individual to occupy as their space, rather than providing them with decent accommodation and food inside in hotels and similar environments. When you look across the world, you see leadership in all its forms and deficiencies at the present time. We've seen significant leadership from Mrs. Merkel in Germany, and we've seen really good examples of leadership from the governor of New York State, Andrew Cuomo, who's very articulate and who engages with the public in a very open way. In contrast, you know, and without mentioning names, we can see the failures of leadership of people who haven't stepped up to the mark, who've tried constantly to explain things away, to minimize the possibilities of this epidemic, and to really avoid taking the difficult decisions. We've seen here actually outsourcing of the responsibility for taking decisions. We saw the outsourcing of the responsibility to close schools to head teachers. We saw the outsourcing of the ensuring that the food supply is fairly distributed to the supermarkets. We saw the outsourcing of the decision about sports games to be outsourced to the FA and to others, you know, and a failure for actually the people whose job it is to make decisions, because that's the primary role of government, is to keep its people safe. Thank you, all those people who've been sending in questions. I'll try my best to answer them. If I don't know the answer, I'll tell you, because I don't believe in bluffing. I will tell you what I know, and I'll tell you what I don't know. Richard Prosser asks, assuming that health services get overwhelmed in due course, then would it make sense for people to go back to work? If people cannot be treated for any condition, then why not go back to normal? I think the point about that, it's a bit of a confusing question, Richard, but in a sense, if we are overwhelmed, there'll still be people out there who haven't been infected. And if people are going back to work when they may still be able to infect somebody else, that's going to make matters worse. So we've got to see this through. We've got to continue to take the measures of home isolation and separation between people who are going out and about and doing essential work and volunteering. We've got to keep that separation as long as we need to, till we get past the hump of this epidemic. I mean, at the moment, because London and the Southeast was ahead of everybody else, it looks as though the deaths in that part of the country will come sooner than in other places, and that was likely to peak maybe sometime in May or into June, but other parts of the country will follow later. And there may be subsequent waves that we're not aware of yet because of the lack of testing, secondary waves from people who've been infected by people who've been incubating now. So this is going to roll on into the summer at least. And if we do get a major second wave, it may well go on into the autumn. And I think people who are thinking about the future of whether it's your household or whether it's a small business or whether it's a school or whatever, need to be planning initially for 3 months, but then for 6 months, and then till the end of the year. They need to be thinking about those different time horizons. Ashfaq Ahmed says, is there any chance that people will now begin to understand after this pandemic that we could be in a much worse situation if we don't get a grip on climate change? I think this is an interesting question to make that link, because, you know, the debate about climate change has been very fraught with climate change deniers and scientists and all of that. And I would hope that people, having experienced this major shock to the system, would now begin to take it much more seriously and to marginalize the flat earthers, if you will, who've, you know, never accepted the science about climate change. The danger is that once this is over, we'll go back to normal and we'll just, you know, go back into our own corners. And we must really make sure that doesn't happen. And out of this comes a mature debate without having the peddlers of fake science and fake news and opinion based on nothing other than fear, perhaps, of the climate change. So just hiding their head in the sand. We need to make sure that we now make progress on this. And maybe some of the things that have been happening, reducing travel, reducing mileage, being more local consumption, local growing of food, all these things may contribute to really getting to grips with the climate change agenda in the years ahead. Tim McConway says that there are many small studies that show that antiviral immunity boosting properties of vitamin C. And he's asking why people aren't being advised to take vitamin C because it's cheap and readily available. We don't know what the benefits are of vitamin C with corona. We do know, generally speaking, that vitamin C is good in fighting off colds and that kind of thing. And at this time of the year, at the end of winter, people's vitamin C levels may be low. Vitamin C comes from a healthy diet with citrus fruit and veg. And if we're under the weather, having additional vitamin C is not a bad thing to do. The good thing about vitamin C, in contrast to some other vitamins, is that if you do have more than your body needs, then you just pee it out because it's water soluble. So you can't get a toxic dose readily on vitamin C. So that seems to be a reason for saying, you know, be pragmatic about that. Don't really be dogmatic about that one. Now, Flat Eric says, I've heard of a higher viral load making for worse infections in individual cases, like medical staff with greater exposure. And I think there are two sides to this. I think there's there's the exposure to lots of virus, which is something which you will get if you're in close contact with people, which is why we do the spacing, why we're encouraging separation, because this being spread by droplets and coughing and sneezing and all of that. But then medics talk about the viral load as being about the levels of viral particles in the blood once you've acquired an infection. And it does seem that people who have higher levels of viral particles are the ones that really are likely to experience the more severe illness. Kim Warburton asks, what's known about reinfections? We know how it's happened in a few cases, Kim says, but health people on news are always saying we assume. Virologists would tell you that once you've had a viral infection, you will have antibodies to that specific virus, and that you are most unlikely to be able to get the same virus twice. It will mutate in the future, in a future year, and if this virus becomes part of the background of viruses like influenza virus, then it will change from time to time. And if we have a vaccine, they will need to change the strain of the corona that goes into the vaccine in the future. So that's the important bit about that. But the shedding of the virus, if you're infected, seems to be able to go on for as long as 37 days, which is worrying if that's true, in terms of people like the Prime Minister resuming work after 7 days of self-isolation, if he's still shedding the virus. I think we need more clarity on that matter from our scientists. The other thing is that people might have tested negative earlier on, and then tested positive during the course of the infection. So there's some ambiguity about the length of time which people may be shedding virus. So, that's something which we really have to be careful about. And I don't think there's been very much discussion about that in these press conferences in Whitehall yet. Tom H asks, when the worst of this has passed, how can we hold government accountable for the herd immunity strategy and for all the issues that have been raised? Well, this is where the politics proper will kick in, as we go forward. And in a vibrant democracy, politicians and governments must be held to account. And the right place for that is in Parliament, but it's also in the pubs and clubs and shops and coffee houses of the country when we're allowed to get out and about and start talking to each other again. But in the meantime, there's a very vibrant conversation going on online, including here in Double Down News. And, this is something which is to be encouraged, but it's best to be constructive, supportive, and not negative at this stage. Stephen Lane asks about the consumption of sulfites, with particular reference to sulfites in wine. Sulfites are used as a preservative in a variety of foods, in black tea that's to be found, in peanuts and eggs, pickles, dried fruit, and they work as an antibacterial. Seem that sometimes the sulfites can make asthma a bit worse. And so if that's an issue, then you need to be careful about the sulfites. But I don't think there's any really strong message about sulfites. The message about sulfites in wine is the message about wine, which is in moderation, as with alcohol generally during this. You don't want to impair your resilience and your resistance by drinking too much. Eric Jarvie is asking, why is the government afraid to test? I don't know whether the government's afraid to test, but all the words that have come out, all the explanations come out, imply a lack of planning, a lack of ordering, a lack of arrangements, a lack of capacity. And we really wait with a sense of urgency at the stepping up of the testing, way beyond just the frontline health workers, the people who are delivering goods to our houses at the moment. They need to be regarded as frontline workers too, but also in order to know exactly what's happening in this pandemic, where the levels are, which parts of the country, which are the highest, where we need to be doing systematic sampling, sample testing, and also in these high-risk groups like prisoners and other closed communities, people sleeping on the street, we really need to be doing systematic testing so that we know exactly where the virus is and where to focus our attention. Someone who calls themselves Futures asks, just what capacity does the private sector have that could be used in this? 33,000 NHS beds is a drop in a very large ocean, they say. The thing about the private sector is that a large proportion of the doctors who work in the private sector are essentially NHS staff who maybe spend a day or so a week working in the private sector. So, you know, there's not much additional medical capacity coming out of that. The private sector does employ a lot of its own nurses and other clinical staff as part of the teams that they have there. And the beds will be useful if properly deployed. But what's clear is that really those locations are probably best used, as now seems to be going to be the case with the XL Nightingale Hospital, not for the very seriously ill people, but for the less seriously ill people, because they're not geared up to be places where people are very seriously ill in large numbers. So it's best to keep the NHS hospitals for the people who are seriously ill, requiring intensive care, and to care for people who aren't so seriously ill in lower intensity settings, probably including many of the private hospitals that are now being brought into the fold. Now, Charlotte Scott is asking about specific measures that to take when her doctor husband comes home from work. She says he will work in scrubs that are left at work and wash carefully before leaving work and shower on getting home. Should he put clothes in the washing machine? Now, these are all good questions. You know, we're still seeing nurses traveling around in the community in their nursing gear. They shouldn't be doing that. People should be going to work in one set of gear, changing at work, changing back before they come home. When they come home, taking the shoes off at the door, taking the clothes off, putting them in a hot wash at least 60 degrees, having a shower immediately themselves, and really paying attention to the biosecurity of the home and of the household. Now, in the old days, of course, the miners used to come home from the pit and have a scrub up in the tin bath in the kitchen. It's beginning to sound a bit like that, because this is novel for the kids. It could seem a bit anxiety provoking, so it's necessary to make this into the ritual of the family day. You have to recognize that when your husband comes home after working hard all day, caring for very sick people, he needs to decompress, he needs to relax, he needs to recharge into the bosom of the family, and the family needs to create that nurturing and supportive environment, and the kids need to be managed in a way where this doesn't create stress in the environment by laying it on thick about the risk. It needs to become second nature, that's casual and it's done properly, but without getting all agitated and wound up about it. Shamrock is asking, do we really believe the official numbers coming from China? Now, you know, I don't think that now's the time to be worrying about the numbers coming from China. I think early on we had some doubts about the Chinese figures. They seem to have improved a lot when we got into February, when the WHO started working with China. And the Chinese have shown amazing solidarity with other countries around the world, sharing their experience openly, publishing their treatment protocols and the lessons learned, sharing them with everybody around the world. So I think we need to be positive about the Chinese now. We need to go forward with this as we go on. And hopefully, one of the things that will come out of this global emergency will be an increased sense of global solidarity and less warmongering and fighting between the countries of the world who will have shared in the battle, the war against this virus together. Les Malloy is asking if we can ease the restrictions in 12 weeks, what would be the approach from then onwards? Continuing social distancing and contact tracing? And how likely are we to repeat what we're going through now in December and January? I think this is an unknown quantity. I think, you know, we're in for this for at least 3 months, almost certainly 6 months, maybe to the end of the year. We've got to get prepared for this. It may be possible to ease off some of the restrictions in some parts of the country at some point in the future, but we're in for the medium haul here at the very least. And so what we need to do is adapt to that, get our routines in place, get our family routines, our daily routines, share the workout in the household, get the teenagers washing the dishes, doing the things that need to be done to get by, rediscovering, as many people are, home bread making, knitting, family board games around the table. We need to have survival, and we need to find ways of having time out individually, in our own room perhaps, to decompress within the household, because we all know what it can be like after 2 or 3 days at Christmas when all the family's together. We have to recognize that and find ways to avoid the tensions that may be inevitable in these kind of conditions. I hope you found this useful. Keep the questions coming. Join the future of journalism. Join Double Down News on Patreon. John Ashton, signing off.